Good morning, everyone. I'm Dr. Meenal Patil, Medical Manager for Sanofi, and I extend a warm welcome to one and all who has joined. First of all, thanks a lot for choosing this webinar to attend on this Sunday morning. Just a quick instruction. I'm sure all of you are very well aware about the Zoom platform these days, but it's a webinar setting. And so if you have any questions, then please put them in the Q&A box, which you can see on your screen. So now, coming to today's session. So today, we are having this session endorsed by Indian Academy of Allergy with an esteemed speaker and panelist who are very well known to all of you, and they do not need any introduction at all. However, we are very much obliged to have them with us today. And with this, I would like to give a quick introduction to the moderator, which we have today with us, who is Dr. Soumya. So Dr. Soumya is an associate professor at St. John's Medical College. She's a secretary of Indian Academy of Allergy, and she's a member of various other associations as well. She had been a principal investigator of 3 ICMR and 1 DST research projects. She has been she's having multiple international publications and have given lectures at international allergy conferences as well. Also, her areas of interest are allergy and rhinosinusitis. With this, I would like to hand over the session to Dr. Soumya. Over to you, ma'am.
Thank you, Meenal, for this excellent introduction. Today, we have a very interesting panel plus 2 talks of a very relevant situation of what is happening in India. So we will be speaking about COVID-19 and the allergies also, because we have a concomitant virus and an allergy season as well. We have to battle 2 epidemics or 2 diseases at once. We have very esteemed panel members who are present. We have Professor Ruby Pawankar from Japan. Then we have Dr. Randeep Guleria, who is the director of All India Institute of Medical Sciences. Dr. Dhar, who is a pulmonologist from Calcutta Medical Research Institute. And Dr. Ashok Mahashiur, who is a pulmonologist at Hinduja Hospital from Mumbai. So we will start this session, this valuable session, with the talk from Professor Ruby Pawankar. Professor Ruby Pawankar is current president of Asia Pacific Association of Allergy, Asthma and Clinical Immunology. And she is also the past president of the World Allergy Organization. She is currently serving as Professor of Allergy in the Department of Pediatrics at Nippon Medical School in Tokyo. She has received several awards. To name a few, the International Distinguished Fellow Award, the American College of Asthma and Allergy Award, and the World Allergy Organization Gold Medal Award. Also, she has been the recipient of Pravasi Bharatiya Samman Award from the President of India. Besides her clinical and teaching assignments, her research has resulted in 562 publications with a huge H index of 75 and totally 36,875 citations. She's also an editor of prestigious journals and books. So we now invite Professor Ruby Pawankar to give us the first talk. Ma'am?
Thank you very much, Dr. Soumya. That was a very kind introduction. I'm very pleased to be part of this panel of extremely well-known and established leaders from India to celebrate the APAAACI Allergy Week, which is on COVID-19, allergies and vaccines, understanding the facts and the myths. I also appreciate Sanofi for organizing this event for us. I give my warmest regards to Dr. Soumya, Dr. Guleria, Dr. Dhar, and Dr. Mahashiur for being on this webinar. And also warm greetings to all of you who are listening to us, and we look forward to increased collaborations. What I'm going to talk in the next 30 minutes that I have is on COVID-19, allergies and vaccines, and managing allergies in the pandemic. As you know, I'm sure you're all familiar with this. It's not new that this is the course of things that happened with the SARS CoV-2, the evolution of the disease entity, with the first case being reported on 30th December, virus isolated on 7th of Jan, genomic sequence of the virus was done on 12th of Jan. Bats as an origin was reported on 21st. And then when the Chinese New Year started on 23rd Jan, Wuhan went into a lockdown. Global health emergency was declared on 30th of Jan. COVID-19 and SARS CoV-2 were actually given their official names on 11th of Feb. And then the ultrastructure or the host receptor was identified, and the ultrastructure was reported to be ACE2 receptor, which is similar to that in SARS-CoV-1. And then in the middle of March, it was declared, the World Health Organization declared it a pandemic. At that particular time, most of us thought that this disease would be a problem of just 2020 and that 2021 would be free from this. But we are still in the midst of all this, and it's a common enemy we have to work and fight against. This is actually about a week old, and there's the dashboard from the WHO showing that the global situation of the confirmed cases, and this is of course now much more multiplied even with the number of cases increasing in India and the number of deaths, and also in Japan the number of cases are spiking. So when you look at this scenario, you see that we are nowhere through this. We are right still in the acute phase of the disease, and this is a very, very important aspect, because this instructs us that not only the vaccination, but also public health measures like preventative strategies are crucial to be able to get over this disease. Now, when you talk about the SARS-CoV-2, I'm sure most of you are aware of this, so I'm just going to quickly just say a few points. There are multiple different proteins on this SARS virus. So you have the S protein or the spike protein, which is the most important, which actually attaches itself to the host cell. Then you have the envelope protein, which actually causes cell stress and apoptosis. Then you have the membrane protein, which actually inhibits the type 1 interferon. And so also the N protein, which is the nuclear protein, which also stimulates apoptosis and so on. But it's a spike protein that actually is crucial, which binds to the ACE2 receptor, as you can see here. So this is a SARS-CoV-2, and you find that the ACE2 receptor, so the virus binds to the ACE2 receptor on type 2 pneumocytes and also the vascular endothelium. Once it actually docks itself onto the pneumocytes, it then goes through the circulation to the other parts of the body and causes disease itself. And this is a study looking at the different cytokines and comparing at the more severe cases, whereas the less severe cases. So you can see here the ICU COVID cases and the non-ICU cases with the controls. And what I'd like to highlight here, because this is a very busy slide, it's very difficult for you to see this intricately, is this part. Focus on this part and you will see that the plasma concentrations of IL-2, 710, GCSF, IP10, MCP1, MIP1 alpha, and TNF alpha were higher in the ICU patients than non-ICU patients. Now, what does this tease us? Does it mean that we need to have anti-cytokines to all these different cytokines? No, not necessarily, but we need to understand which is more important and which is more important at what stage, because every treatment that we give is not necessarily to be given at any phase of the stage, whether it's mild or it's severe, whether it's in the early stages, whether it's asymptomatic. Depending upon all these different aspects, the treatment will vary. So if you just generalize the biomarkers of the cytokine storm, you can see C-reactive CRP, the TLC, D-dimer, LDH, ferritin, procalcitonin, CD25, interferon, IL-1 beta. Now, the other important thing is, what are the risk factors that would actually play up in this or cause more severe disease? Now, this was a study done in China more than a year back, and you can see here that they looked at the non-severe cases versus severe cases, and it's summarized out here. So the risk factors of severe pneumonia are shown here, where the clinical outcomes are poor in those who are having comorbidities like hypertension or diabetes or obesity. Again, if you're more older, this is again a risk factor for severe pneumonia. Again, if the CRP levels are high, the IL-6 levels are high, and the ESR is high, is more prone to have more severe pneumonia. And this was a survey we did. Again, this is just a survey. It's not like a rocket science. So a survey did in 14 countries in Asia. And we looked at the common comorbidities among confirmed patients of COVID-19, done as part of an APAACI study. And as you can see here, you can very clearly see that hypertension, diabetes, cardiac disease, COPD, these were very common comorbidities amongst these patients who had COVID. But asthma and other allergic diseases were relatively very, very low frequency. And when we look at that, I'd like you to focus here. And this was an Italian study actually done way back during their first phase of the first wave of COVID in Italy. And you can see the Lombardia area, Piemonte area, Veneto area, all these places where there was high numbers of COVID patients. The severe asthmatic numbers were very low, indicating that asthma may not be a comorbidity of COVID-19. Now, what's the hypothesis? Again, these are all hypotheses. We don't have any clear cutting edge evidence for everything that we are speaking today, because there's a lot of evolution that's happening at this time, both for the disease profile and also for the mechanisms. So you can see here what happens in COVID-19. We all know that the ACE2 receptor is upregulated. So also the TMP-RSS2 is upregulated. Pro-inflammatory cytokines are upregulated. Interferon is downregulated. Macrophages, CD8, T, a lymphocyte, and lymphocytopenia, and a cytokine storm. And basically from the M0 macrophage, you get an aberrant antivirus immunity leading to the development of inflammatory M1 type of macrophages. On the other hand, in asthma, you can see there's downregulation of the ACE2 receptor and the TMP-RSS2, and the innate immunity you get, of course, less interferon, but increased MBL and SPD. Now, these MBL and SPD are surfactant proteins that actually compete with the SARS CoV-2 to bind the ACE2 receptor. So again, this is increase in this would actually cause less binding of the SARS CoV-2, or less sites for binding for the SARS CoV-2 on the available ACE2 receptors. And you have reprogrammed macrophages, ILC2s, induced NK cells, increased CD4 positive cells, and then we have the antiviral effects of the treatments for asthma, like inhaled corticosteroids and monoclonal or biologics like anti-IgE. And in this case, you have a trained immunity and you have reprogrammed or the M2 macrophages. So in this study, when they looked at the impact of interleukin-13 on the nasal epithelium of expression of ACE2 receptor in the nasal epithelium and bronchial epithelium, you can see IL-13 negative. That means when there is no IL-13 in the epithelial cell culture, and here is IL-13 positive. And similarly, for the bronchial epithelium, the presence of IL-13, addition of IL-13 actually downregulates the ACE2 receptor. And when you do a challenge, what happens is challenge? Again, a nasal allergen challenge and a bronchial allergen challenge, you will see same situation where the ACE2 receptor is downregulated by the allergen challenge, indicating that this may be one of the reasons why asthma is not such a frequent comorbidity of COVID-19. So the potential different reasons I just said is one, of course, adherence. Patients are more adherent. There's a study showing both for asthma and for COPD that patients are 14% more adherent, even in a small window of 2 weeks when they did it, assessed it, they found that the adherence is really much better. The other, of course, as I said, is downregulation of the ACE2 receptor and the TMP-RSS2. And the third thing is that inhaled corticosteroids, and I will come to that because there's some data on budesonide, might prevent or mitigate the development of COVID infections. So what does one say for patients with asthma? What's the advice? The advice is to please continue the prescribed asthma medications, especially inhaled corticosteroids. Have a proper asthma action plan. And this is crucial because the asthma needs to be well under control. The other important thing is avoid nebulizers. And this is very important because nebulizers increase the risk of disseminating the virus to other patients and to healthcare professionals. So pressurized MDIs via a larger spacer is preferred, and of course with a mouthpiece or a tight-fitting face mask. Now, having said that, we need to take the treatment, the patients with asthma need to take their inhaled corticosteroids, need to take their medications to keep control, to avoid the use of exacerbation, the induction of exacerbations. What are the other important things? This is an important paper actually done by the World Allergy Organization and looking at the role of biologics in COVID-19 and asthma. Now, should biologics for severe asthma be used differently in the COVID-19 era? And the PRO study actually shows that, for example, omalizumab was able to reduce the duration of rhinovirus infections, viral shedding, and risk of rhinovirus illnesses. So omalizumab could diminish actually the asthmatic response in patients inoculated with rhinovirus 16. Similarly, mepolizumab and benralizumab and dupilumab all have indicate there's no available data regarding the risk of increased infection with the use of these monoclonal antibodies. And this is a recommendation that comes up from all the different societies, be it the American College, the American Academy, or the European Respiratory Society. So they highlight very clearly that as in the placebo-controlled studies with omalizumab, mepolizumab, and benralizumab, and reslizumab, and dupilumab in asthmatic patients, no risk of increased infection susceptibility or immunosuppressive effect was reported to date in these cases. So we do not need to discontinue the biologics. Now, stopping biologics in people who are already on that and control with that might also give a risk of acute exacerbations and the use of emergency room visits or oral corticosteroid use. So therefore, it's not recommended. But how would we use it? Well, biologics are usually given in the hospital, and of course in Japan right now we still have in-person consults, and it's possible in many countries, but where it is not possible for patients to actually visit the doctors themselves, in some of the countries now they are training the patients like we do for EpiPen to actually, or insulin, to actually inject themselves. So self-administration is also being taught. How practical it is in our scenario in India would be a matter of discussion and a matter of debate. But in any case, in countries like in Italy and other countries, it's being now recommended as in the form of self-administration at home. So the patients are actually taught how to self-administer the biologic. Coming to allergic rhinitis. We know that allergic rhinitis also is a very prevalent allergic airways disease like asthma. And according to the current knowledge, in patients with COVID-19 infection, intranasal corticosteroids should be continued or can be continued in allergic rhinitis at a recommended dose. And stopping it is not advised because controlling the allergic rhinitis again is crucial not only for allergic rhinitis, but also for a better control of the asthma. So the recommendation by the ARIA-YACI guideline group actually is that please continue to use your intranasal corticosteroids for allergic rhinitis. What about immunotherapy? For immunotherapy, again, like if it is subcutaneous immunotherapy, well, if it is for venom immunotherapy, I mean, it's a life-threatening thing, so it has to be continued. Again, if the patient can visit the hospital, there is no problem in continuing it. But again, if a patient has to cannot visit the hospital and has to, take medication at home, then of course the recommendation would be to use other controller therapies and a temporary suspension, and then to revisit the situation when the COVID is under control. And those who are on sublingual immunotherapy, however, can of course continue their treatment as scheduled because it is already anyway home administered. But home administration of injectable immunotherapy is not recommended. The other interesting point is a recent publication talking about pollen concentrations and COVID. Now, this is very interesting because it says higher airborne pollen concentration correlated with the increased SARS CoV-2 infection rates, as evidenced by study done in 31 countries. Now, this is a study just looking at the infection rates and the pollen concentration, but this is all mixed up with the humidity, the temperature, the pollution, the population density, and lockdown effects. And when you look at it, I mean, they have shown that there's a 44% increase in the infection rate. Now, this kind of a report needs further much more evaluation because when you're talking about the airborne pollen, the pollen does not, it's a very huge particle, does not enter the airways because of the particle size. The usual way that pollen enters and causes huge asthma attacks is when you have thunderstorm asthma. And when you have thunderstorm asthma, what happens? The pollen gets swept into the cloud, and in the moisture of the cloud, it is actually broken down into minute particles of 2.5 micron, like a PM 2.5, and then they descend down on the earth in that form. So in that minute form, they are respirable. And then they actually cause acute attacks of asthma. But the pollen, on the other hand, on a large size does not. But it can have an effect in the sense that we know that pollen with the air pollution can actually aggravate the immune response of the epithelial cells and cause more inflammation. So a mechanism like that might happen, but this requires much more evaluation and more robust studies before we can come to some conclusion on this. So this is again the same situation with air pollution. Now, in air pollution, as I will show you in this slide, you can see that there are four figures here showing the PM 2.5 concentration over across the periods of the high density of the SARS CoV-2. And all these showing is when the SARS CoV-2 was high, the pollution was quite high. And what actually they have reported here, that there was a tripling of the infection rate with an average increase of the PM 2.5 from 10 to 22 microgram per cubic meter. And they also showed that correlated with the mortality rate and the case fatality rate, which is the deaths to infection ratio. And they also concluded by saying that this mechanism is because PM 2.5 causes an overexpression of ACE2 receptor. So if there's an overexpression of ACE2 receptor, there's more binding of the SARS CoV-2 virus, and this can lead to, of course, more infection and more viral load. And again, the high atmospheric NO2 can provide a second hit by causing a severe form of SARS CoV-2 in the ACE2 depleted lungs, resulting in a worse outcome. Again, this, if you can see, this is a data summarized by my intern who actually just published a paper early this year, showing that this kind of data on the pollution and the COVID-19 infection is positive in some situations, but does not show any correlation in certain situations. Of course, we know that when the lockdown was there, the air was very clear, there was no pollution. There probably might not be any asthma attacks at that time, but and we all know that pollution induces asthma attacks, but we don't know the actual full relation with COVID-19. But the tendency of many studies showing a correlation and the justification, as I mentioned out here, that this could be the factors that play an important role. And pollution, again, can act with the pollen because pollutants, again, increase the allergenicity of pollens, and that, again, can play a role indirectly in causing the increased infection rate that was reported in that study. So those kind of studies need much more evaluation before we come to some kind of a conclusion on the direct impact of the pollen on the disease. Now, just to summarize a little bit on the current vaccines, and we know that we have the CoronaVac, the Sputnik, the AstraZeneca, the Pfizer, Moderna, and J&J. And we also know that there are different forms, the mRNA, the DNA-based, the adenovirus vector, there's inactivated forms, so different ones. And we know that the Sputnik and AstraZeneca and the J&J are the viral vectors, and the CoronaVac is inactivated virus, whereas Pfizer and Moderna are messenger RNA vaccines. Now, what I'd like to highlight out here is, because there is always a big issue of vaccine hesitancy. That is a problem. The other end of the paradigm is, having been vaccinated, is the complacency that now that I'm vaccinated, I'm fine. I don't need to do any public health measures. I don't need to do any precautionary measures. So there's a danger on both sides of this situation. So you look at the adverse effects are not so much. And of course, if you look at the anaphylaxis is with Pfizer or with Moderna, it's really one 0.11 per 100,000 and 0.25 per 100. So very, very low compared to what number of anaphylaxis we can get with the drugs or with food allergies or venom or other things. So it's very low. And for that, what we need is to have a very good risk stratification strategy, which has been done by CDC, EMA, FDA, and also many of the health ministries across the world. And the issue about the blood clots, again, if you look at it, yes, we need to pay attention to the side effects. We need to understand why it is happening. We need to see if there is an age stratification, what is the cause and how we can avoid those things. But again, it is very few compared to very small percentage, and all vaccines have side effects. So that is also something we should keep in mind, especially when we explain to our patients and to the public, for them to actually not have that kind of public fatigue or public or vaccine hesitancy. And the mechanism of the blood clots are again being studied, and most likely it's not much of an issue of platelet aggregation, but more of an autoimmune reaction to the platelet factor 4. But again, it's still under studies. What about vaccine immune mediated reactions? We have the IgE mediated or immediate reaction, and we have the more delayed one. So this is minutes to less than 4 hours. So basically the ones that we get commonly seen in anaphylaxis, with urticaria, angioedema, bronchospasm, or gastrointestinal symptoms. And the other one, which is more delayed, is more T-cell mediated. And then, of course, you have the non-IgE mediated or the autoimmune inflammatory form of side effects, the pseudo-allergic one. Now, the recommendations by the CDC and the MHRA, that is UK, and what APAAACI has drawn out from based on these and some health ministries is that if you have a severe allergic reaction after a previous dose to a component of COVID-19, or if you have an immediate allergic reaction of any severity to a previous dose of known allergy to a component of the vaccine, or to the polyethyl glycol or polysorbate, which are excipients present in the mRNA vaccines, then it is contraindicated. And this is uniformly agreed across the different governments and health ministry. Now, what are the special precautions you need to take? Well, there are many patients who have allergies to foods, allergies to drugs, allergies to different latex and so on. But we don't have to prevent them from having vaccines. They can be given vaccines. There are some countries, of course, like Singapore is very strict. They actually do not give it to patients with food allergies also. So here, the recommendation is that if there is an immediate allergic reaction to other vaccines or injectable therapies, people with a contraindication to mRNA COVID-19 vaccines have to have precaution for the J&J, which is now back. Actually, J&J is again back approved by FDA because they contain PEG and they contain polysorbate. Again, if you have anaphylaxis to multiple different drug classes which trigger an unidentified reaction and the trigger is not known, the trigger could be PEG. So one has to take special precautions. Or if there is anaphylaxis to a vaccine or injected antibody, monoclonal antibody or a medicine that is likely to contain PEG, like a depot steroid injection or a laxative, then again, one has to be careful, or if there's idiopathic anaphylaxis. Now, what are the actions that we do? We need to do a risk assessment. We need to refer to an allergist immunologist who has the knowledge of how the patient should be managed. And again, the 30-minute observation, unlike 15 minutes, which is normally done, and pre-treat. And well, this again is not uniformly done everywhere. In some countries, such pre-treatment is not necessarily recommended, but in other places, pre-treatment with the H1, H2, and Montelukast have been recommended in those who have a history of anaphylaxis to food allergies or other triggers. So the clinical approach here is you basically have a clinical history, you have positive history of reactions after vaccine administration. If it's a non-immediate reaction, then you work up. In most cases, of course, the vaccine can be given according to the general recommendation. If there is an immediate reaction, then skin test can be done, either intradermal or a prick test or in vitro IG testing. Again, this is usually done with the vaccine itself or its components or its excipients, for example, PEG and polysorbate. For that, we can use Miralax or a laxative, and this is commonly done in the United States, not necessarily done here. We don't do it here, but can be done. And if it's positive, then traditionally, yes, we could give the vaccine in graded doses. So you don't give it as the same, you give it in graded doses. And if it's negative, of course, then you go according to their recommendation. But when it comes to the mRNA vaccines, we don't know if that is practical because of the storage conditions. This is again a matter that needs to be taken into greater consideration in the case of Pfizer or Moderna, maybe not so much in the case of AstraZeneca and J&J. And with that, I'd like to just end my talk and hand over the opportunity to hear a very excellent talk from Professor Guleria and, of course, towards the panel discussion. And I'll be also happy to answer questions during the panel discussion. And I'd like to invite you to Kaohsiung, Taiwan. It's less likely that we will have an in-person one, so it'll probably be a virtual meeting this October. And then APAACI 2022 in Philippines, which we hope, with God's grace, we will be out of this pandemic by next October and we can meet face-to-face in person. Thank you very much for your kind attention.
Thank you, ma'am, for this excellent and insightful talk. It was very informative, as always. Now, I request Dr. Randeep Guleria, who is a pulmonologist and the current director of the All India Institute of Medical Sciences. He is also credited with the establishment of India's first Center for Pulmonary Medicine and Sleep Disorder at AIIMS. He was honored by the Government of India in 2015 with Padma Shri. He is also a part of India's COVID-19 response effort, or rather, I would not say part, I would say he is the man behind the COVID-19 response team and the decisions taken by India. So welcome, sir. We are eager to hear your talk now on COVID-19, India's resilience, vaccine, and the future.
Thank you very much. Thank you for inviting me. And it's indeed a pleasure to be here to give my talk. And I'll just share my screen so that. Okay, thank you very much. So I'll just take off from where Dr. Ruby Pawankar left and just quickly run through my first few slides because there may be a little bit of a repetition. But we all know that COVID-19 started as a novel coronavirus in Wuhan district in China, and it has rapidly spread to become a pandemic. We also know that viruses are pathogens which exist in the gray area between living and non-living, and they really sort of hack into the host cell machinery and force it to make copies of itself. Sometimes the replicating copies tend to change, and this leads to the emergence of new variants or mutations as we know them, and that have caused a huge concern globally as far as these viruses are concerned. It's a single-stranded RNA virus which has the spike protein, the and the envelopes outside, which has given it the name of the coronavirus. Now, I think it's important for one to understand that there has been for many of us who have been working on outbreaks and pandemics, there has been this fear that we will have a pandemic of this nature almost for the last 15 to 20 years. It started in the late 1998 when we had an outbreak of H5N1, which is known as avian influenza, again in South China and Hong Kong. And this was again a virus which had jumped species but had not attained the ability for sustained human-to-human spread. But it had case fatality of over 60%. That means 60% of people who got this died, especially those who are poultry workers. And this was because this virus has the ability to very rapidly move into the lower respiratory tract, causing extensive pneumonia and ARDS. Luckily, this did not become a pandemic, although at that point in time, WHO and CDC had raised an alarm because of the fact that research had shown that you needed only 2 mutations in this virus for it to become a pandemic virus. But we've had many other outbreaks since then. We had the SARS outbreak, the MERS outbreak, we've had Ebola, we've had Zika, and all of these have actually been some sort of, I would say, warning, including the H1N1 pandemic, that viruses are moving, they are jumping species, and because of a lot of climate change that has happened, and increasing animal to human interactions, we will see pandemic, and I'm sure this is not going to be the last pandemic that we will see in the near future. COVID-19 is a viral respiratory disease. Majority of patients, 80%, are asymptomatic or have mild illness. 15% have a moderate illness in the form of a pneumonia, and less than 5% actually go into a respiratory failure or go into multi-organ failure or sepsis or ARDS. The mortality continues to be low, around 1 to 2%, but it does also lead to significant degree of what we call long COVID or post-COVID sequelae, which many patients can have, and we have some patients who actually are on long-term oxygen therapy because of the extensive damage that COVID can at times do as far as the lungs are concerned. We all know that it is a droplet infection, but there is more and more data emerging, and there are recent articles which show that this can also be in the form of an aerosol, and that is why wearing a mask properly has become more and more important. Because initially it was felt that these were large droplets, more than 5 microns, and they would not travel very far. They could not stay suspended for a long time and would quickly drop to surfaces. And therefore, it was felt that if you had a distance of more than 2 meters and you were wearing a mask, you should be protected. But we now know that this virus can stay in the form of aerosols in the air for quite some time, and especially in the indoor environment where ventilation is poor, this can lead to transmission occurring even in people who are more than 2 meters away and are still susceptible if they are not properly protected. The pandemic has really caused a huge morbidity and mortality. If you look at data that has emerged, this is one of the worst pandemics since the 1918 Spanish flu, and we have a large number of people affected. In the US itself, COVID-19 was declared as the 3rd leading cause of death in 2020. So it's rapidly rose up as a cause of mortality. Remember, I was saying that only 1 to 2% is the mortality. Despite such a low mortality, the number of cases was so much that it led to a huge deaths as far as the absolute number was concerned. And even if you look at data from 2021, it is now one of the leading causes of mortality as far as the US is concerned. And this is something which we're seeing in many parts of the world too. The situation in India is grim because we are now seeing a huge surge as far as the second wave is concerned, and our positivity rate has climbed dramatically over the last few weeks with a huge number of cases being reported in India. And therefore, if you look at the data which is there from the 15th of April, India has a high positivity rate as far as the nation is concerned, which varies between 10 to 20%. We have, because of our population size, we have the highest number of COVID cases and the third highest, we have the second highest number of COVID cases and the third highest number of COVID-related death. However, if we were to convert this into number of cases per million or the number of deaths per million, India is much lower down as compared to many countries. But because of the absolute number of population, we have 1.3 billion people, and the fact that we live in a very crowded environment, the virus spreads in this situation and finds this as an ideal environment for human-to-human transmission. If we go back to 1918 Spanish flu pandemic, and this has a lot of learning if you were to read the literature and go back in the history reading, the second wave was much bigger than the first wave. And this happened because after the first wave, many individuals felt that the pandemic was over. They started having parties. Social distancing, wearing masks was no longer done at that point in time. And at that point in time, we didn't have any antibiotics. We had no antivirals. And this led to a huge surge as far as the second wave was concerned. Something that we're seeing today also. Also at that point in time, there was a very high mortality, even if you look at the data from India, which is available as far as British India is concerned. Various parts of India, the northwest frontier, the Bengal region, had a very high mortality even during the Spanish flu for reasons which are quite similar to what we are seeing today. At that point in time, masking was also very, very important. It became something which was done aggressively, and yet there was also resistance. Mask resistance during the pandemic isn't new. In 1918 also, there was a huge resistance to wear masks, and again, it needed to be implemented very, very aggressively. The world is currently experiencing a second wave of COVID-19 pandemic, and this is what is seen globally. And this is also seen as far as India is concerned. We're having this huge spike. And if you look at the rate of rise in the cases, it's really very, very dramatic. This is something that we really need to address, and that is something that needs to be done. We also need to see what did we do in the past where we were able to bring the peak down, and how can we repeat it now? So what we did in the past was we had a stringent lockdown, there was physical distancing, there were precautions like universal masking, which has become much less, and there was public education. We ramped up our treatment strategy, and we have now a huge number of labs which are able to do testing, both RT-PCR, the CBNAT, TrueNAT, and we have the rapid antigen testing also. There was serosurveillance which is being done regularly, and there are now vaccines also which are being used. So we started initially with travel advisory, then there was guidelines for surveillance, there was a contingency plan way back in March 2020, and then there was also the Prime Minister's Citizens Assistance and Relief in Emergency Situations Fund. We had a lockdown on the 24th of March, and subsequent unlocking phases started. We started off with the testing strategy, and now we have almost more than 2,500 labs in the country which are able to do testing for COVID-19. And there are other various mechanisms like pool testing which have also been developed and being tried in our country. Vaccines has already been covered. We are manufacturing now 2 vaccines, the AstraZeneca vaccine and the Bharat Biotech vaccine, and the Sputnik vaccine also is being manufactured now by Dr. Reddy's laboratory. We started off with a huge shortage of PPEs, and now India is actually exporting PPEs and N95 masks. As far as the All Institute of Medical Sciences was concerned, we started very actively. We realized that we have multiple things to do in terms of protecting healthcare workers, motivating healthcare workers, and basically also working as mentoring and capacity building for other institutions across the country. In February itself last year, I had set up a COVID-19 task force. We would meet daily with the faculty members, nursing officers, residents, our OT technicians, and take stock of the situation. And we are still doing that. And we are really working aggressively now because of the huge surge. We also developed a human resources committee so that we could pool all our resources, whether it be the faculty from different departments, including non-clinical and paraclinical department, or residents from different departments. We have now ophthalmological residents working in residents from physiology, residents from orthopedics, all trained in managing COVID-19 patients and trained in hospital infection control practices so that they can be part of the team as far as management is concerned. So all of these strategies were taken up at one by one. We also realized that research has to continue. So we started our own intramural funding, and we've funded more than 200 research projects on various agents from our own resources as far as research in COVID-19 is concerned. And we quickly moved on to an academic program which we had based on a platform which we were using known as a SARL platform for training and teaching, not only for hospital infection control practices, but for our undergraduates and postgraduate students also. We converted a National Cancer Institute, which is a 700-bedded cancer hospital, totally dedicated with its own OPD area, its own research area, and own auditorium, into a COVID hospital. The Vishram Sadan, or the rest house there, was converted into a COVID care center. During the lockdown, trauma had come down, and we converted our trauma center into a COVID hospital, and we created more than 1,700 beds for managing COVID patients, and almost 250 ICU beds. All of our beds, or I would say the 1,700 beds, have oxygen points, and 250 have facilities for ventilators also. Last year, we were managing 800 to 900 patients per day, and we've reached the same thing. Today in our hospital, we have now more than 900 patients admitted, with almost 100 patients in the emergency waiting for a bed. And therefore, we are having a huge surge as far as the number of cases are concerned. This is a National Cancer Institute. The building at the extreme left is north is our main hospital. In the middle is the OPD, and on the left is the auditorium, and behind is the research block. Across the road is the residential apartments, and the building coming on the left is the Vishram Sadan being made by Infosys. This is the ground picture, and on the left, the building that is coming up is the Vishram Sadan for around 800 rooms for patients who would come for chemotherapy and would need to stay here for some time. This is the trauma center, which is about 260 beds. This has been converted into a COVID hospital also. Behind this, we have what is known as the Burns and Plastic Surgery Center, about a 100-bedded hospital. That hospital has also been converted totally into a COVID center. So we are actually expanding daily, opening up new areas as the surge is happening as far as the number of cases are concerned. But important to remember is that we have to work on both sides. We have to also work on decreasing the number of cases. We improve our infrastructure, we've improved facilities, but we need to bring the cases down because no healthcare system can sustain itself unless the cases start coming down. And therefore, there is a need for aggressively looking at community mitigation processes. We have to delay and flatten the epidemic peak and reduce the burden on healthcare systems. And this can be done by aggressive non-pharmacological measures, which will help to flatten the peak and give time really to manage patients and to be able to decrease morbidity and mortality. The treatment options we all know are antiviral, oxygen therapy, anti-inflammatory, and anticoagulants. And by and large, more than 85% of patients require just supportive treatment. The timing of treatment is very, very important. And we all know that we have this whole of the phases of the stage 1, the stage 2, and stage 3 as far as the disease is concerned. In the first stage, that is stage 1 in early infection, there is more of viremia or there is a viral response phase, and supportive treatment is all that is required, and most patients will recover without much treatment in this stage. Many people in India give hydroxychloroquine, ivermectin, or favipiravir, although the data for all of these is not that strong enough, and majority of patients would recover even without any other treatment with just supportive management. Patients who go into stage 2, when they start having fall in their oxygen saturation or the fevers becomes much more, are the ones who need to be monitored carefully. Many of them or most of them would require hospital care as their saturation starts falling. And these are the patients who would benefit from remdesivir, convalescent plasma, and if they have features of fall in oxygen saturation, corticosteroids would be useful along with anticoagulants, because as was just shown, there is a hypercoagulable state as far as COVID-19 is concerned. Very few patients go on to what we call the cytokine release syndrome or the cytokine storm, which is a hyperinflammatory phase. And in this stage, you need to give drugs like anti-IL-6 drugs, tocilizumab, which may be useful in decreasing the cytokine damage which may happen. Now, what are the likely causes of the second wave? Moving on. I think what has happened, we were in a very good position in January and February when our cases were really down, and a lot of people, like what happened in 1918, felt that the pandemic is over, the vaccine is now being rolled out in our country, the vaccine has started, and therefore there was relaxation of COVID-19 precautions. Schools opened, theaters opened, gyms opened, and there were large public gatherings. There was also laxity among the public, feeling that the pandemic had ended, and therefore there was indoor gatherings without wearing masks. Marriages were done. Many marriages and functions which had been postponed were now being done at a very rapid pace. Along with that, we had the arrival of mutants from the UK. The UK mutants, we had certain variants which happened in India itself. And all of this led to a huge surge in the number of cases. And this is what we're seeing right now. The new strains that we know about are the UK variants, the B117, the South African lineage, the B1351, and the Brazilian lineage, the P1. And we know that all of them have many mutations, and many of them are at the spike protein. And these mutations have the facility to increase transmissibility. That is, the virus now can transmit itself much more easily. It has the potential to attach more easily and more firmly to the spike, the ACE receptors. And this itself is causing a huge increase in the number of people getting infected. There's also a concern, and there's data from South Africa which suggests that, especially as far as the AstraZeneca vaccine is concerned, that there may be an immune escape mechanism, and the efficacy of the vaccine may also become less. So these are things that we need to keep in mind. How can we tackle the second wave? I think the most important thing is, like I showed in a few slides before, we need to really look at non-pharmaceutical measures, community mitigation measures like COVID-appropriate behavior. It has to be aggressively followed. Vaccine has to be upgraded so that more and more people are able to get themselves vaccinated. And there has to be some degree of lockdown to break the chain of transmission and prevent the infection from spreading from one individual to the other. Keep in mind, this is an infection which has spreads from human to human. It's not one which spreads through mosquitoes or through any other means. Vaccines have been touted as a weapon to win the war, and this was what was in the US newspaper, which came out in December. But there are other warning notes that vaccines alone will not end the coronavirus pandemic, and therefore it's very important to remember that there is a dash of hope, but we need to look at it critically, and we have to protect ourselves against what is vaccine-induced hype, because this has led to decrease in one's guard and has allowed the virus to actually spread. So vaccines for COVID-19, and vaccines have been there for a long, long time. Edward Jenner gave the first vaccine in 1796. And at that point in time also, if you read the literature, there was a lot of vaccine hesitancy. This was a vaccine from cowpox. And there were pictures which came out which suggested that people who took the vaccine would grow cow heads on their arms and things like that. So vaccine hesitancy is not new, but this is an effective public health measure which can be used. It has been now used and millions of people have got the vaccine, and this has led to widespread optimism. But questions do remain as we roll out the vaccine. Are the vaccines truly safe and effective? I think we have enough data now to show that they are safe and effective. Will they prevent disease transmission is something that we need to address, because they do prevent severe disease, but the data for transmission needs to be more robust. How long will the benefit last is something that we don't know, and this is another issue that do we need to really look at revaccinating people at some point in time, and will vaccines work against the new strains is another important question. Now, COVID-19 vaccines induced immune response of the host against pathogens without exposing them to the disease. And we have a large number of vaccines which are being brought out. I mean, this is the first time that for any infection, for any virus, that we have over 180 candidates which are being studied in preclinical trials and over 16 candidate vaccines in human trials. But it's important to remember that vaccines may, ideally, if you want a vaccine, it should prevent infection. But we're not sure whether all vaccines can prevent infection. Most of them cannot. But they are definitely there to prevent illness or prevent disease. They will prevent intensive care unit admissions, they will prevent hospital admissions, and they will definitely prevent death. And therefore, it's important to remember that these are important parameters that we need to keep in mind. We would also like vaccines to prevent the transmission so that the chain of transmission can be broken. But currently, if the vaccines don't prevent infection, they may decrease the duration of infectivity, but you may still have a person who may get COVID-19 infection after vaccination, and that is why it's very, very important to have COVID-appropriate behavior even after vaccination, which also is not being followed that aggressively. Whenever we look at a vaccine program, we look at development and production, but importantly, we also look at affordability of the vaccine. Is it affordable for the large number of people who need to be vaccinated? Can it be deployed? Because remember, there are certain vaccines which have to be kept at minus 70 degrees centigrade. That will not be practical for most parts of the world. So the deployment policy strategy also needs to be looked at. And then, of course, looking at the allocation and prioritizing it so that we have limited doses to begin with. How do we allocate it to those who need it the most? If you look at vaccine production capacity, various vaccine capacities that have been outlined are significant for this year. The Pfizer vaccine has 1.3 billion doses that they would have in this year. The Moderna will have about 500 million to 1 billion doses. The AstraZeneca will have 3 billion doses, and Covaxin, which is the Indian vaccine, should have around 700 million doses available as far as these vaccines are concerned. But it's important to remember that as far as the AstraZeneca vaccine is concerned, the Covishield or Covaxin, these are the vaccines which are easy to use because they can be used in the existing infrastructure as far as cold chain maintenance is concerned. Like I've already said, we have a large number of vaccines, and these are the various candidate vaccines which are being looked at. Even in India, there are many vaccine candidates which are undergoing research trials, and hopefully we should have other vaccines available in our portfolio to be used. We have Covishield by the Serum Institute of India, Covaxin with Bharat Biotech. The Zydus Cadila is coming out with the DNA vaccine, which is ZyCoV-D. Sputnik has already got emergency use authorization by our regulators. Serum Institute is coming out with Novavax. We also have Biologically and Genova coming out with their new vaccines, which is under undergoing trials, and Bharat Biotech is also looking at another vaccine platform. So there is a robust platform as far as vaccines are concerned in India, and hopefully we should be able to get more and more vaccines in our kitty. The key thrust areas for any vaccine development program has to be a rapid scientific discovery of safe and effective vaccine, followed by rapid and large-scale manufacturing of quality vaccines, and then there has to be equitable distribution of vaccine to those who need them the most. Now, this is very, very important because developing vaccines is only half of the work done. Delivering it equitably is the most important step. And it's been shown in a large number of papers that if the vaccine were distributed only to high-income countries, we would be able to prevent only 33% of deaths. But if the vaccine were distributed to all countries proportional to the population, 61% of deaths could be avoided. And that is why various programs like the COVAX program of the WHO are very, very important because of the equitable distribution of vaccine, which is very, very important. Now, it's also important to remember that 5 wealthy nations plus the EU, which accounts for 13% of the global population, has more than 50% of the vaccine already pre-ordered. If you look at various states and the number of vaccines in various countries and the number of vaccines ordered per person, it's staggering. Some countries have ordered almost 6 to 8 doses per person as far as the vaccine is concerned. And that is why COVAX, which has secured 700 million doses and looking at 2 billion doses for equitable distribution, is something that we really need to look at, because vaccines unless we give vaccines to everyone, we will not come out of this pandemic, because mutants will develop in areas where vaccination is not there, and these mutants will travel to other parts of the world, and even those who have been vaccinated would be susceptible to get infection again because of the immune escape mechanism which these mutants will develop. Cost also becomes an important issue, and if you look at the Indian vaccines, both the Bharat Biotech vaccine and the AstraZeneca Oxford vaccine, they are very, very cost effective as compared to other vaccines where the cost is much more as far as the cost is concerned. Vaccine hesitancy is something which is important. WHO had listed it as one of the top 10 global threats of 2019 because there was a huge hesitancy as far as vaccine is concerned. And this could be a major obstacle globally in trying to get over this pandemic. And therefore, there is a need for all healthcare workers to come together to really change public perception as far as vaccine hesitancy is concerned. And this is basically related to multiple factors. If you were to look at the data which is emerging, vaccine characteristics, efficacy, duration, safety, side effects, all are issues which people have raised. And they're concerned about the approval process. It was too fast. Was it politically influenced? And also the source of information. Many of the individuals look at source of information which is through social media, which is not that reliable and sometimes creates confusion. And that is something that we need to keep in mind. It may not be a big problem in our country, as this paper tended to show in the Lancet in 2021, that when they asked the Indians, 91% of people who the survey looked at were ready to get vaccinated as far as India was concerned, although this may have come down to some extent because of the fear which has subsequently been raised because of the blood clotting, the so-called vaccine-induced immune thrombotic thrombocytopenia. But we need to keep people aware of the fact that this is a very, very rare side effect. The vaccine rollout program is one of the largest in the world that India has started, and we continue to vaccinate a huge number of people. As of 11th April, more than 12.9 million people are fully vaccinated, and 91.6 million received at least one dose. And this is a huge number, and this keeps on increasing. And this is something that we need to keep on doing. Also, data from the Indian Council of Medical Research is very, very encouraging. They have data which suggests that the vaccine that has been developed are safe and are effective against the mutant. NIV has recently successfully cultured the double mutant, the B1617, and has shown that the vaccine is effective in neutralizing the double mutant strain as well. So there is data which is being looked at to see that the vaccine are effective against the current variants which are emerging. Vaccine delivery has been developed using what is known as a CoWIN platform. The CoWIN platform monitors logistics, vaccine from the manufacturers reaching all the way up to the primary health center, maintenance of the cold chain is looked at. And then it also looks at the giving the vaccine to the individual. The first target was 30 crore individuals. So the vaccine, right from its beneficiary registration to session allocation to vaccination, followed by the unique health ID, the QR code based certificate, and monitoring for adverse effects following immunization is all done through this CoWIN platform, which is a web-based platform and is can monitor all of this at one go. Now, the issue is that could COVID-19 vaccine be tweaked to cover new coronaviruses? And this is something which is an issue because of the emergence of variants. And this is something which is not new. There is little evidence currently to suggest that the variants are developing a significant escape mechanism against the current vaccines. But there is a concern that in the future, we may have mutants which could render the vaccine less effective, and therefore vaccines may have to be tweaked in the near future. This has been done in the past also. Every year, the influenza vaccine is changed because of the antigenic drift which happens in the influenza virus, and we all know that we every year get a new strain. Both the quadrivalent vaccine, which covers 2 influenza A and 2 influenza B strains, is changed both for the northern hemisphere and the southern hemisphere based on the virus mutating. And that will possibly have to be done at some point in time as far as COVID-19 is concerned. So the pandemic is not over yet. Eventually, COVID-19 is likely to become a circulatory respiratory virus with its own seasonal peaks and troughs. Vaccination and possibly repeated vaccination will confer immunity among the population, but it will take time. And emergence of new strain is a cause of concern. But we still need to have COVID-appropriate behavior. Also, we must look at the lessons that we learned from the 1918 pandemic, which clearly showed that good restrictions, stricter policies were associated with lower mortality even at that point in time. Those cities which had stricter policies did much better in terms of mortality and also in terms of manufacturing employment subsequently as compared to those who did not. Also, we must remember that wearing a mask is very, very important because it prevents infection even when we're talking of droplet or aerosol infection. The future is that we must understand that pre-existing conditions are leading to the birth of this pandemic, and they still exist. What led to this pandemic has not gone away, and therefore we have to understand that rapid urbanization and with crowded living condition and the loss of animal habitat with increasing cohabitation is also responsible as far as the pandemic is concerned. And this has led to so many of the outbreaks and pandemics that we have seen. And this is something that we need to address as we go ahead to prevent ourselves from future pandemics. There's also the concept of One Health that we need to start talking of. Human health, animal health, and plant and environmental health is also very, very important because we need to work together. This is something that promoted a lot, that human health and animal health are interdependent as well as being linked to the health of the ecosystem of which they are a part. And that is what has been shown, whether it be antimicrobial resistance or pandemics, that we have a shared environment. We have to have a safe food and food systems, and that has to be looked at in a very holistic manner. If we looked at this, we should keep in mind that 60% of human pathogens are of animal origin. 5 new human diseases appear each year because of this, and 20% of animal production losses are caused by diseases globally. So this is something that we also need to keep in mind. So to conclude, COVID-19 pandemic is not over yet. Another spike is being seen. Physical distancing, masks, and vaccine have been the key tools to bring the pandemic under control. And we've known that since the 1918 pandemic. We still need to follow this very, very aggressively. Current vaccines retain efficacy against the viral variants, but we may have to tweak the vaccine in the future as new variants will emerge. And more research is needed to explore the genesis of the pandemic from a One Health perspective to understand how better to deal with future pandemics. Thank you very much.
Thank you, sir, for this very useful and reassuring talk, especially with all the despondency and negativity that is going around nowadays with respect to the COVID-19 situation in India. Now, I think we will move on to the panel discussion. I will also introduce the two panelists, Dr. Raja Dhar, who has joined as Director and Head of the Department of Pulmonology at the Calcutta Medical Research Institute. Dr. Dhar brings with himself more than 27 years of experience in pulmonology, critical medical management, and interventional pulmonology. Currently, lead of the team drawing up the ICS Adult Respiratory Vaccination Guidelines. Welcome, sir. Also, we have Dr. Ashok Mahashiur, who is a pulmonologist in Mahim, Mumbai, and he has an experience of 31 years in this field. Dr. Ashok Mahashiur practices at Hinduja Hospital in Mahim, Mumbai. He completed MBBS from Nagpur University in 1972 and MD TB and Chest from University of Bombay in 1976. He also did his FRCP from Glasgow, UK in 2005. So now we will start with the panel discussion. I will start with the first question to Dr. Mahashiur. So do you feel the occurrence of exacerbations of airway disease would be in any way reduced due to the use of masks?
Well, I think if we presume that COVID virus leads to hyperreactivity of the airways, or the pollution leads to hyperreactivity of the airways, I think wearing of the mask has definitely reduced the incidence. What we see nowadays, especially in Bombay, which is a highly polluted city, the incidence of exacerbation of asthma and COPD has drastically gone down, mainly because there is less crowding, less pollution, and people are taking utmost precaution to wear a mask. So I would say that for preventing any respiratory onslaught or respiratory disorder or irritation, mask is a very important tool, and therefore the use of it should be encouraged even in the normal life. That's it.
Dr. Raja, what are the features you envisage would change permanently in the management of asthma and allergy in the post-COVID era?
Thanks, Soumya. Absolute delight to be here.
Hello.
Just wanted to add something with
morning, sir. Morning,
what Dr. Mahashiur said, and I'll answer your question after that. So I think in the last 2 years, so 2020, 2021, we've seen far lesser number of exacerbations of airways disease, be that asthma or COPD, coming in hospitals. And I think along with the reasons that Dr. Mahashiur said, there's also this problem that people are actually hiding away at home with the fear of COVID and not coming into hospital. So when you get a patient with an exacerbation coming in, they're actually coming in a far worse state as compared to what you would normally see patients coming in other parts of the exacerbation. So I think that's something which is worth remembering. The fact that I think lockdowns helped a lot. Now the number of exacerbations with no lockdowns are greater as compared to what you saw in a similar time frame in 2020. So I think those are factors, and sort of going forward, these cannot be solutions, but you can tell how much of a factor pollution is in causing exacerbations of airways disease. I think Randeep wants to put in a word. Dr. Guleria. Okay, so that's one. Answer to your question, what's changed? I think a lot has changed in the management of airways disease. I think the first thing is with diagnosis. So with the fear of aerosol generation with various lung function techniques, lung function examinations like spirometry, for instance, the problem is that we have to base our diagnosis of asthma and COPD more on clinical features. And there are various clinical algorithms, questionnaires that have been developed, especially in the diagnosis of asthma. So we realize the clinical diagnosis of asthma is eminently possible, and spirometry is just add-on information. COPD is slightly different. You do need, as per the current guidance, whichever international guidance, including GOLD, you go by, I think you need a spirometry to establish a diagnosis of COPD, but you can suspect based on triggering factors, based on your history and so on and so forth. So the diagnosis has become more clinical based as compared to being lung physiology based. The other problem is that the consults that we're doing nowadays have become more virtual consults. So we as clinicians do not manage to put the stethoscope on the chest or talk to patients face to face. It becomes a virtual consultation. Hence, we have to become more astute in seeing your patients at a distance on a virtual platform like we are seeing each other today, and come to a diagnosis or prognosticate or say how good the control of asthma or COPD is based on conversations like we're having on this platform today. So that's the second change. The third change that we see as far as management is concerned, especially when we talk about management with nebulization. So when you're acutely unwell patients with airways disease come into hospital and require nebulization therapy, that being an aerosol generating procedure has been a bit hairy. The nebulizers causing spread of infection is still, the jury is still out, I think, but we try and avoid nebulization in COVID wards as far as possible. That's for sure. At home, there's been various guidelines that have come in about nebulization at home and people not being in the same room when you're nebulizing in well-ventilated rooms so that the aerosols, if generated, can actually move out of the room, and people not coming into the room, people who don't need nebulization not coming into the room immediately after the nebulization has been completed, and staying out for about 30 minutes is what the guidance says now. So multiple changes, the others too, and I'm sure we'll discuss them as we go along in this particular talk.
Yeah, excellent, Dr. Rajai. Very good info. Nebulization and spirometry is something that it's very difficult for us to follow these days. And like you said, it's like a virtual consultation. So you have to be an astute physician to pick it up. Now, Dr. Guleria, is Dr. Guleria there?
No, I think he has left.
Actually, we were trying to take his questions first. He had to leave. He has another commitment. Mm-hmm. So you could address the question to us, and some of us will answer. So,
can I ask Soumya? Can I ask one question to Raja?
Sure, sir. Please do.
Raja, if a person gets COVID and he gets cured of it, after how much interval can he take a vaccine?
I can answer.
So Ruby first.
Yeah, the data is like this. There's 2 stages. Depends on the severity of the infection. If the severity is mild and the person has not required oxygen and like any kind of moderate to severe treatment, generally you can give it up to 4 weeks or so after the infection. It's not 4 to 6 weeks. However, if the severity is more, if there's more severe disease, then the advice is to wait for 12 weeks. Otherwise, it can land up in a serum sickness kind of situation because you're loading the antibody formation on a body that has already produced antibodies from the initial infection. This is the global recommendation.
Yeah. So there's Indian recommendation, Dr. Mahashiur, very much in line with what Ruby said. So 6 weeks across the board is what the ICMR says. And they say if you've got severe infection, which required support like non-invasive ventilation, HFNO, etc., then you do a antibody level beyond 6 weeks. And if memory serves me right, if IgG levels are less than 50, you take it at that point of time or wait for another 6 weeks. Otherwise, if the levels are more than 100.
If you had given a choice for vaccine in the COVID epidemic, and if you had access for all the vaccines till date, whatever has been manufactured, what would you suggest is the best?
Well, any vaccine which has a longer duration of life and the antibodies formed are faster and long-lasting with least incidence of anaphylaxis or the allergic reactions. That's what I would prefer. Now, currently, we have very little choice. We have either Covaxin or we have Covishield. And we can't choose anything third in that order. Therefore, whatever is available currently, I think people are opting for it and taking it. But by and large, it has been found that Covaxin is more efficacious, more better lasting, with least side effects.
Okay, sir.
Yeah. May I add something to it?
Yes,
Dr.
please.
Yeah. Dr. Mahashiur. Yeah, what I'd like to just say is that our recommendations from the Asia Pacific organization, also based on global guidelines, is that, as you rightly said, we have to look at what Dr. Guleria also addressed in his talk, we have to look at what's feasible in our country. I mean, you cannot manage to keep mRNA vaccines, which are like -70 and -80 in India. Transportation is a huge issue. And then even doses, you have to give 6 doses altogether. Otherwise, they cannot be maintained at room temperature. So those kind of things limit our use of mRNA vaccines. But having said that, the general WHO recommendation is if a vaccine has an efficacy above 50%, then it is acceptable. And most of the vaccines that are currently available all have an efficacy above 50%. On an average, it's between 75 to 95%. So as you rightly said, and I'm sure Raja would also agree, what we are trying to say is whatever vaccine you have, take it. The adverse effects or the side effects, whether it's anaphylaxis or blood clot, are so few, are so low percentage that if you look at the history of vaccines in whether it's polio or measles, all of them have side effects, and influenza too. So relatively, the frequency is much, much less. So the best thing is to take the option that you have.
Thank you, ma'am.
So in line with what Ruby said, we keep talking about blood clots and the Astra vaccine. So think about it this way. If you had a patient with severe COVID, the incidence of thromboembolic disease is about 18 to 20%. So that's any COVID patient who requires oxygen. So severe COVID, the incidence of thromboembolic disease of some form is 18 to 20%. And if you look at the number of thromboembolic disease in Europe, I mean, we don't have reports from the country, but in Europe, it's 4 out of 1 lakh. So that's the sort of comparison that you're talking about. And I think that information, that bit of fact needs to be driven home to the audience and to the larger audience who's listening to us or will hear about this, that the comparison of taking it and getting thromboembolic disease versus not taking it and getting COVID and getting thromboembolic disease, there's a huge disparity between these two.
Absolutely.
Yeah. The other thing I wanted to talk about is these mRNA vaccines, and maybe I'll quiz Ruby about this. So to the best of my knowledge, we've never had an mRNA vaccine before. There was one for Ebola, but that never got popularized because the efficacy never got established. And these mRNA vaccines are against the spike protein. There's a lot of hype. So if we take away the storage part of it, the fact that transport of these vaccines are difficult, and just talk about efficacy, do we think that these mRNA vaccines, the Moderna vaccine, actually adds anything onto the Covaxin or the Covishield we have in this country today? Or do you think that's just a different way of preparing a vaccine?
No, absolutely. In fact, the technology of mRNA vaccine was established 20 years back. It's not new. It was already established 20 years back. It was, so it's not a new technology. The biggest challenge is its use and its storage conditions. As long as those can be managed, both the mRNA vaccines have efficacy of more than 95%. And because it's an mRNA, it's even safer actually, and it actually causes antibody production. And there is no, there was a rumor at some point of time that there's kind of, you're introducing mRNA into the body, so that can cause some kind of a autoimmune phenomenon, especially in those who are immunocompromised. But that's not what is happening because it's mRNA to the spike protein. So I would say that it still stands above others. But again, there's no head-to-head study. There's no head-to-head study between the vaccines, so nobody can really say which is the best. The second thing which I'd like to also raise is often people ask, if you have a reaction to the first, and what can you do? Can you change your vaccine and take another vaccine as the second for the second shot? Again, that is something that is being tried. Studies are being done now. The companies are coming together, and never in the history of our lives have we seen companies working together like that. Like, Pfizer with AstraZeneca, Moderna with working together to see that if you have a reaction to one, the second dose with another vaccine will be fine and equally effective. So that, again, we don't have the answer for that now, but it's under studies.
One last question to Dr. Mahashiur. Sir, how would clinical trials on airway disease be affected in the COVID era?
The thing is, both COVID as well as non-COVID mediated studies are affected because of this pandemic. The reason, of course, is the fear of infection. Now, it is necessary to do some research, especially on the modes of therapy, the mode of therapy, the clinical outcomes, etc. However, FDA has put a blanket ban on all the studies. Therefore, we are in fact at a loss to hear this. Now, whatever the studies that could be done are based on the video consultations type or apps, different apps, but they are not going to be as genuine, as representative as the real world studies. When it comes to the aerosol generations and the coughing, the studies for the airways, they are definitely affected because of the fear of the contamination of the aerosols. And therefore, I think overall, I would say that the COVID pandemic has definitely limited our ability to research and also to get more knowledge about the disease.
Okay, sir. Thank you, sir.
Yeah, and also one more point I was just raising, maybe just for Raja and sorry, Raja, you were supposed to ask, is that when we do these clinical trials, especially for asthma and things, FEV1 is also, and spirometry is one of the things that we would actually use as an outcome. And again, with the thing of advising against the use of nebulizers and spirometry, again, that's also, I think, a challenge in the clinical trials.
Thank you. Soumya, I have other program waiting. So I'll join it once that is over and you're still on. Okay?
Okay. Yes, please. We would wait for you. We welcome you.
Yeah. Very valuable thoughts you shared with us. Thank you, sir.
Yes, Raja. You were.
Dr. Raja and...
So, Soumya, let me ask you one question. Okay. Right, if that's okay. So, Soumya, I heard from the ICMR yesterday. So, I was having a chat at one of these task force meetings yesterday. And the NIV is coming forward with an intranasal vaccine. I don't know whether Randeep mentioned that during the course of his talk or not. But it's the colonization of the virus in the nasopharynx and the local action of an intranasal virus, and you being otorhinolaryngologist. Do you think that's going to make a huge difference? Is that something that you would look forward to going forward? Or do you think, like influenza, where the intranasal vaccine did not seem to work as well as was hypothesized, do you think this is going to be more hype than effect?
It's a very, very interesting question, Dr. Raja. And it's fascinating because I personally feel that, the SARS COVID virus has a great affinity to the olfactory epithelium. So it is going to go first to the olfactory epithelium, it is going to multiply there and then reach the other parts of the body. And also the nasopharyngeal tissue as such is very rich in lymphatics. So the chance of getting better immunity, if you give it as a nasal spray perhaps, is that the virus goes and the weak virus will go and localize with the ACE2 receptors which are present in the olfactory epithelium. And then they multiply, and by then the powerful lymphatic supply in that region will help in giving better humoral immunity and also cell-mediated immunity. This is, of course, my conjecture. I really don't know if it will work. I think it is much better than giving a shot in the blood. So let's see what happens.
Actually, just to add to what Soumya very nicely put, intranasal route for vaccination has been something that has been looked at for long, because also of the absorption. The absorption rate is much better intranasally. In fact, if you remember, even insulin was being tried intranasal. So intranasal as a route of absorption has always been. Immunotherapy was tried in the past, intranasal, but didn't really work. So I think there's a good prospect, like based on the things that she very correctly said, and also the nose being the real outermost gateway for the whole respiratory system. But again, one has to see what happens when it's practically used, whether it will work or not. Yeah, I know there are some studies, even internationally, looking at the intranasal route. And nasal NO is also being looked at.
I think the challenge is probably people don't know how to use nasal sprays. Even if you give steroid nasal sprays, most of the time they don't know how to use it. So that could be one of the reasons if there is a vaccine failure of a nasal spray. Now, I have one more interesting question. Vaccines reduce transmission, severity of disease and mortality, even though one can have milder forms of infection as with other vaccines. So I just want to know if antibodies are the only marker of an immune response, because we are all testing antibodies and trying to see how much antibodies are there in each one's blood after vaccination. What do you think about the other systems of immunity, the innate immunity or the humoral, the cell-mediated, the memory T cells? What are your thoughts on that?
If I may take that first, actually this is the biggest issue. I mean, testing antibodies, again, there are multiple issues. First of all, we need to have a standardized system for, there are standardized tests for doing antibody testing. The antibody testing are so many multiple tests are being done. Some are standardized, some are not standardized, so you cannot even compare them. So that's an issue. Second of all, one common thing is getting the antibodies. The other is cell-mediated or T-cell-mediated response, which also acts in protecting. So the body's response can vary from either an antibody production or a cell-mediated response. So even if your antibodies are low, if there's a cell-mediated, T-cell-mediated response, it can still protect you. But the most important thing for vaccination, and I keep saying that, like Maria from WHO said, I'll speak like a broken record, and I keep saying, I really want to say that this is not about you not being infected. You have an influenza vaccine. Can you guarantee you don't get influenza? No, you will still get influenza. The important thing is that, as already voiced by Dr. Raja and Dr. Randeep and Dr. Mahashiur, that it reduces transmission to some extent, but mainly it reduces severity and it reduces the chance to death or mortality. So if that can be achieved, and if by vaccinating, which was also addressed in through the COVAX issues, if we are able to vaccinate a large proportion of the population across countries, the rich countries, the middle-income countries, the low-income countries, we could get out of this pandemic. And unless we do that, I think this is going to be very tough. And this is coupled with our, public health measures of precautionary steps. Yes, Raja, please.
So I will add a couple of things. I mean, I completely agree with everything that Ruby said, but some things which were thought-provoking in the first wave of the pandemic. You remember, we said at the time, there were a couple of studies. So one coming out of Japan, actually, and one which came out of India, which showed that the innate immunity of the Asian population seemed to be about 30% greater as compared to the European counterparts. So this is when people in Italy were dying left, right, and center, and the situation was probably similar to what it is in India today. And there was the question of the BCG vaccination and promotion of T-cell immunity in these individuals, and the fact that because most of us are BCG vaccinated, we have that extra quanta of antibody in our body, which might actually protect us against the infection. And now if you think about, so when we talk about antibodies, you can generate antibodies in two ways. One is by getting the natural infection, and the second is by getting vaccinated. And there's a lot of controversy. I have been on platforms where people have actually discussed which one is better. If you had a preference, would you get natural infection-induced antibody or would you get antibody induced by vaccine? And the thought process has been, while your antibody titers might be higher when you get a moderate to severe infection, however, your chances of getting covered against mutant strains, your double mutant strain, triple mutant strain, etc., from a natural infection would be lower as compared to what you would do with vaccination. So this is in line with what you said, Soumya, in the first part of your question. Is antibody the measure? It is not. It is not, because there are various touch points, various endpoints that you're trying to touch on when you talk about immunity and antibody production, rather than just that one IgG level that you measure and you have that you're above 100 and you're doing well.
Absolutely. I mean, that's the complacency issue that has created this situation. I strongly feel that people have lost the guard, and that has led a lot to this current situation.
Raja, what do you think about Africa? Why are they not having the infection like the rest of the world is? Because
so I think, again, it's probably the immunity. I think it's the same T-cell immune-mediated system. So there aren't any studies. So I did a literature search at that time, and there is nothing to talk about innate immunity in the African continent. But we know that the number of patients with TB and the number of people who get vaccinated for BCG is far greater in the African continent as compared to us. If you look at respiratory infections in Africa, so think of the influenza pandemic, for instance, the H1N1, etc. All of the SARS, the MERS, etc. For some reason, even though that's a developing nation, it's an underdeveloped nation, the number of respiratory viral infections in that continent has always been far lower, even when you compare it with Asia. So there is something in their immune system, there's something in their genotype which probably gives them some greater degree of innate immunity as compared to what it does in Europe and even to some extent in Asia.
There's one more question I always keep wondering, See, we always talk about animals transmitting viruses and all sorts of infections to humans. Do we also transfer to them? I don't know.
Yeah, so I mean, did you read this? I'm sure you saw this. Tiger COVID. Did you actually? So I don't know who did the nasopharyngeal swab for the tiger.
One tiger at the zoo.
Yes. Right. So I think we do. I think we do transmit the infection. I think the good thing about the animals is that they act more as being reservoirs of infection rather than being manifesting infections. I think the clinical features of infection. So the mortality, even with the H1N1, where you have various reservoirs, or influenza for that matter,
correct,
you've got various reservoirs, you've got the pig, you've got the hen and so on and so forth. But even with these reservoirs, they don't actually manifest the disease or they don't die, but they just act as reservoirs and transfer infection to humans.
Yes.
For sure, humans can transmit infections to animals. Whether they have manifestations of that infection is a different story altogether, I guess.
No, because pet dogs in patients with COVID positive homes, they're completely fine. The pet dogs go around everywhere, the cats. So it's quite interesting. We should probably see their genome and try to do something with our
Very
genome.
Interesting thought.
Can we take some questions from the audience? For the persons who are suffering many diseases, such as autoimmunity with a lot of comorbidities, and they're not eligible for vaccination. So do you have the best solution to protect them to avoid the SARS CoV-2 virus? And for them, is it possible to have the same right like vaccination passport? Because they also as citizens want to go freely everywhere like a healthy person. This is the question asked by one of our audiences today.
Can you just repeat the question in brief again? I lost my train of thought somewhere in the middle of that question. Soumya, can you repeat that for me?
Persons who are suffering from many diseases such as autoimmunity and who are not fit for vaccination, what is the best solution to avoid SARS-CoV virus in them? And can we give them an immunity passport or a vaccination passport?
So I'll tell you what. So I completely agree, couldn't agree more, 110% with Ruby. In my book, there would be extremely few contraindications to vaccination. I think that's the first thing. So I think this question that gets asked to people, are you allergic at all before you get vaccinated, is to the detriment. I think if you're asking, are you allergic? Most people in this country and outside would say that they're allergic to something or the other.
Yes.
If you stop vaccinating, you would probably stop vaccinating 50% of the population. So if they're allergic, the next question should be, what are you allergic to? And what happened when you took that substance? Did you have anaphylaxis? And you can describe in layman's terms what anaphylaxis is. So in my book, the vaccination passport can only be provided to people who are vaccinated and not otherwise. And in my book, 99% of the population, or 99.9% of the population can be vaccinated. And it's only that 0.1 very rare people who might get anaphylaxis to any of the vaccine ingredients or have had anaphylaxis in the past to something who would probably not be vaccinated. So I think that's the key point. Rather than thinking about autoimmune disease, there is absolutely no reason why someone with autoimmune disease cannot be vaccinated, in my understanding.
Correct.
Yeah, I fully agree with that. In fact, that's what I actually showed in my slide, where I showed two. One is the clear contraindications, and the other was the special precautions. So if you have patients, which is, like, I mean, in India, for example, there are also people who don't know they are allergic to something, right? They don't know they're allergic to some food. I mean, they have some allergic reaction. They go to a hospital. They're sometimes not even diagnosed as having allergies. So, I mean, those kind of situations are not an issue. The issue, as Dr. Raja has also said, is typical reaction to PEG, polyethylene glycol, which is or polysorbate, that is present in these mRNA vaccine, AstraZeneca vaccine, and in case of Sinovac, which is the Chinese vaccine, that is aluminum hydroxide. So if you have a particular reaction to these particular excipients, or some component of the vaccine that is present in some other vaccine in the past, or you have a reaction to the first dose, that is the only time you would not give. And I don't know about this vaccine passport and things like that, because that's a big question. I mean, I've had both my shots. I don't think I'm going to get a vaccine passport to go to Switzerland. So that's a very big question. I think unless the pandemic is controlled, travel is not going to be the same as we presumed or wished for, So.
And the next question is, do we need a third dose of COVID vaccine?
Well, I'll take that first, and then Raja can
Please.
Well, this is, again, we don't know. It's unanswered. It's a question that we can't really answer, because right now we have 2 doses. The issue is how long the antibody will last in our body. As far as we know now, the current knowledge says approximately 8 to 10 months is what we're seeing. Now, whether this pandemic will become like influenza and remain as a community disease within the community, and we have to take a shot every year like we take for influenza, that is one aspect. The other aspect is, okay, you've had 2 shots, and do you need another booster shot or not? That is something that still needs to be studied. And anything that you do, unless there is evidence behind it, even for emergency use, you need some form of evidence. Unless there's evidence, it's very difficult to make a recommendation.
Ma'am, many countries have been hoarding vaccines for the next 2 years or 3 years, like US, Canada, and so many countries. Per person, they have some 9 vaccines or 4 vaccines. Do you think it's a smart thing to do, considering the fact that this virus is going to mutate? So this existing vaccine might be useless. So rather they give it to countries and distribute it across the world so that mutations can decrease.
Well, that's a very idealistic situation. I mean, if I were in charge of the whole world, I would love to do that. I'm sure you would do, and Dr. Raja would do. But the situation is every country wants to protect its own population, that they will prioritize their own population. Now, as was, I think, also addressed in the lecture of Dr. Guleria, and I don't know if I mentioned it or not, but all these vaccines which are there, I mean, of course, there was something about the AstraZeneca and the South African variant, but other ones, the Brazilian one, they are in real time testing it. So Pfizer, in real time, they tested to see its efficacy on the Brazilian list. So it has efficacy. Maybe what is 95% becomes 85% or 90%, but still it's effective. So people want to keep it because they want to give their whole population, and they don't know if the booster is required, in which case. That's number one. The other thing is now NIH is conducting studies on risk, high-risk people. For example, the African Americans and the Hispanics. So they are doing a big study to look at them to see whether they have some special characteristics that would need special risk stratification. So you need, and even they did not have enough vials to do their study. It's just started. It just started about a couple of weeks back, but they didn't have. So I think that's one of the reasons countries are actually keeping a lot. Some of the smart countries, the smaller countries like Singapore, they ordered it very well, and that they've almost vaccinated their whole population. Whereas Japan, we still haven't even vaccinated 2%. In fact, all our healthcare workers, we started vaccinating mid of Feb, and we just still doing healthcare workers while we started the elderly. So we still are short of vaccines. But having said that, before I give to Raja, I just want to say one thing is that the COVAX is actually doing a great job in trying to bring those vaccines to the countries that don't have, whether it's AstraZeneca vaccine or it's the Sinovac. Like, for example, Indonesia has Sinovac, they don't have, and AstraZeneca. Philippines is AstraZeneca and Sinovac, they don't have Pfizer, they can't afford it. So that they get this from COVAX. But even COVAX is running out of their stock. They need more funding. They need more funding to bring that money. Right now, according to the World Health Organization, less than 1% of whole of African continent is immunized. So you see, so it's a huge task at hand. Yes, Raja, please.
No, nothing. I was just going to answer the previous question. So we're doing the 6-month trial. Soumya, in answer to your question. So ICMR has started the third booster dose at 6 months as a trial, which we are about to start. We've not got anyone who's at 6 months from the second dose of the vaccine as yet. But all the papers, ethics approval, etc., is going on. 25 centers throughout the country, looking at about 5,000 patients. Well, not patients, but individuals. And we'll know the results. Like Ruby said, there has to be some evidence before we do it. And whether we do it over 6 months or 1 year, like we do for influenza now, I think is a question that the trial will need to address.
Fine, Raja. There's one more question. So can we say that patients with asthma on intranasal corticosteroids or ICS are less prone for COVID-19 infection, or asthma decreases mortality?
Well, I'll take that answer.
I think it's part of your
actually, I already addressed that in my talk.
Oh, yes.
That asthma, if you look at the epidemiological data, asthma is not really a comorbid. And that was surprising. We were all surprised when even we published a paper on that in Allergy. Because if you look at rhinovirus, influenza, you always think that, asthmatics are more prone to it. And it isn't. And that the mechanism what we hypothesized is because of the ACE2 receptor being downregulated and all the things I mentioned there, TMPRSS2 being downregulated, there's increased CD4 T helper cell, and the mitigation by inhaled corticosteroids. That is one thing. So asthma is not really a risk factor. However, also the fact is that asthmatics are much more compliant now than they were ever before in their medication, and so also patients with that, because they are afraid. So they're much more compliant than they were in the past. So that itself mitigates the risk factor. And finally, there is the recent paper of inhaled budesonide actually helping, which may be possible because it's inhaled, and maybe inhaled cyclosinide or inhaled fluticasone may also work. Other such similar inhaled drugs may also work. But again, I think the timing is very important. Every particular drug will have a particular timing. If it's a mild case, this is very early stage. Mid stage, this is what you do. Late stage, this is what you do. You have to have that kind of stratification in order to really say something. You cannot make a cocktail and give everything at one go for just because you're scared and you give everything to come our case, something will work, kind of thing, No,
there is one question on inhaled budesonide, when it should be added for the treatment.
So, Ruby, you want to go first?
No, I would just say it's early.
Yeah. So we are doing STOIC 2, funded by Oxford, 5 centers throughout the country. So fantastic. The STOIC trial results were exciting. So there are a couple of things, very thought-provoking things, and I would want comments from both of you. So the first thing about STOIC is that it is the first drug which seems to reduce disease duration by about 3 days when used early, like Ruby said. So that's one. The second thing is that in STOIC, they used a much higher dose. If you look at the dose in STOIC for inhaled budesonide, they were using a whopping 1600 micrograms. So 800 micrograms twice a day. Budesonide is what they were using. So STOIC 2 is using half the dose. So 800 micrograms in a day is what we are using. The other interesting factor, and Soumya, this will interest you too, is that, when we ask people to take inhalers, we ask them to wash their mouth and gargle immediately. Here, we are actually asking the patients to gargle after half an hour.
Oh, okay.
The hypothesis is interesting. So you want the inhaled steroid, which is deposited at the back of the throat, to be there for half an hour. and have a local action in reducing nasopharyngeal carriage. And we're trying to actually look at nasopharyngeal carriage. I'll not go into details because it's outside the ambit, but looking at nasopharyngeal carriage by keeping the drug at the back of the throat for half an hour. Mm-hmm. So there are various things that we are learning as we're going along. So intranasal steroid, for instance, I'm sure you will tell us, has got something similar. So if it stays there, along with using the inhaled drug, it might have an additive effect in reducing nasopharyngeal carriage in these individuals. And I think we are learning, but one thing is for sure, inhaled steroid is good for COVID. It's also good to keep your asthma under control.
Absolutely.
That's very interesting. And I was just wondering, what if they take both inhaled steroids and intranasal steroids? Yeah. Would it help?
Well, if they have allergic rhinitis, yes. If they don't have allergic rhinitis, there's no need to take it.
No. For COVID-19?
Well, I don't think so. I mean, again, we have to have evidence for it. Yeah. We have to have a study. I mean, I had a question that came on my WhatsApp because that person couldn't ask the question directly and was more related to immunotherapy. So I'm just bringing that up. And it said that, is it okay to continue subcutaneous immunotherapy? Should we not stop giving it during the COVID? So there is no reason to stop if the patient can visit the hospital. If the patient cannot visit the hospital, you would rather stop and keep on other controller medication and then restart probably at a lower dose and updose it further. If the patient is on sublingual immunotherapy, of course, that doesn't affect, you can continue the treatment. But self-administration of subcutaneous immunotherapy at home is not advised.
Okay. I'll run through the other questions. Quite a few are there. What's the best treatment for children less than 5 years who have tested positive?
So no treatment. So in my understanding, and I'm sure Ruby will have a comment. So the first thing to say is less than 5, less than 12, the disease incidence is extremely small. We're seeing some patients between the 12 to 18 year age group now, but below 12, especially up below 5, it's very, very low. And even if you get the disease below the age of 5 years, all you need to do is to watch them carefully, isolate them, and feed them properly during the time. I don't think there's any active treatment that's ever been tried, let alone been advocated in children who are less than 5 years of age.
Yeah, because and even if they are infected, I mean, most of them are like asymptomatic.
Yeah.
You know, it's asymptomatic. And then if you're talking about 12 to 18, now Pfizer actually has a approval for 12 to 18 years for vaccination. So that's more like a protective thing.
Is vaccination in children a possibility in the future?
It's already there, 12 to 18, but below that is being studied now by the companies.
Okay. And if I have taken first dose of Covishield, can I take Covaxin as second dose? Is there?
I just addressed that. We just talked about it.
Yes.
We just said that there is no
data.
There's no data for that. There is no data for that, and those are being studied now. People are trying and mainly it's not a choice that you want to make it by yourself. Like, okay, I took Covishield, now I want to take Covaxin. No. If you have a reaction to Covishield, will Covaxin be a possibility? That is being studied. And so studies show that it's fine to go ahead, then the person, right now, if you have a reaction to the first dose, you will avoid the second dose. Now, I also raised in my study, in my talk, that in the past, like for example, for influenza vaccination and all, like when people have a reaction, like you do a skin prick test, you give graded dose. So you give, like, instead of giving one dose, you give it over 3 to 5 doses. You know, you split it and you give graded doses. But that with the mRNA vaccine may be a little bit more tough because of the storage conditions.
Okay.
But maybe with the other vaccines, it's possible.
Raja, last question for you. I realize you also have to leave. So Remdesivir, what are your thoughts on Remdesivir? Because, now they're saying it is of no use. So they just introduce some drug and throw it in the bin and something new comes up. Now Zydus Viralin has come soon.
So I think a lot of this is, I think Ruby will actually add something to what I say in a minute. But my understanding about any drug in COVID till date is that all drugs we've had are repurposed drugs. They are drugs which have been used for other indications and have come into COVID. The reason we have repurposed drugs is because in the middle of a pandemic, you cannot go through the rigorous 1-2 year trials that you would normally do before a drug gets licensed. So the evidence for all the drugs are weak evidence. And that's across the board with any drug that's ever been studied. There have been varying results with remdesivir. I think the crucial point, like Ruby said a little while ago, with any drug in COVID is trying to start it at the right time. So we have gone from starting remdesivir in patients who are on a ventilator to trying to start them as soon as there is onset of hypoxia, or even hypoxia when people start walking. So you do a 6-minute walk or you do an informal walk test and you find the saturations dip below 90, you would be prone to giving remdesivir early to these patients. So I think if you select the right cohort of patients, it's an effective drug. I think it's a no-brainer to say that for a viral disease, an antiviral drug would be something which should be first line. And remdesivir and favipiravir are the only drugs which have shown some effect. So if I had the disease tomorrow, Soumya, I would want remdesivir to be given to me if I fell in that category. The moderate going into severe disease category where I just start requiring oxygen, I would want it for myself. And if I want it for myself, I would want a similar category of my patients to get the drug to. So I wouldn't rubbish it at all.
That makes it very clear, Dr. Raja. Thank you for your precious, valuable time and your inputs and for joining us today. Thank you so much.
Thank you, Soumya, and thank you for doing a lovely job. And Ruby, thank you very much.
Yeah.
Organizing this and to the entire Sanofi team. Thank you.
I have questions for Soumya actually. And this is because, allergic rhinitis is also an important disease that is, but again, not found to be a comorbid condition for COVID. But, what do you think is the current scenario of allergic rhinitis in India? And you've done a four-continent study, a multi-continent study looking at the types of uncontrolled, allergic rhinitis that just doesn't respond to any treatment, kind of thing. So what is the data that you have from that? Can you throw some light on that?
Thank you, ma'am, for this question. Actually, it's quite interesting because since the time COVID started, all our allergic rhinitis patients literally disappeared. So I don't know, is it because they were afraid to come to the hospital or probably because they were wearing the mask all the time, as a result of which they were protected from the allergens. But we saw that there was a drastic decline in these patients. And once COVID abated, the wave subsided, again, there was a spike. So the allergic rhinitis patients seem to be there, but probably they never came to the hospital. We did this interesting study of 5 countries from 4 continents. We chose Africa, US, Europe, and India. And we studied 430 patients with uncontrolled allergic rhinitis and SCOAD, that is severe chronic upper airway disease. We found that there were a lot of, we categorized them as disease-related, diagnosis-related, patient-related, and treatment-related factors for what led to this uncontrolled allergic rhinitis. In India, it was mostly the patient-related and the disease-related. So patients were there who were really not compliant with the medications, or they did not know how to take the medications, or they just felt, okay, let me try alternative systems of medicine. This probably worsened their allergic rhinitis and asthma. The second thing was most of them had deviated nasal septum. So this disturbed the mucociliary clearance, as a result of which this enhanced the allergic rhinitis. So probably this could be because we still conduct a lot of normal deliveries in India, less of cesarean sections. So because of these normal deliveries, probably every other person has some degree of a deviated nasal septum. Another interesting phenotype that we observed compared to the West and India was that the number of patients who had abused tobacco was very less. So they were surprised, India being such a big tobacco consumption country, how come, the tobacco use or smoking is less? That is probably because we had more number of females in our study, in our cohort. And females generally, according to the culture, do not smoke as much in India. Plus, the other thing is tobacco chewing is more rampant than smoking. So these were some interesting findings that we found.
Thank you very much. That was really very interesting to hear. The other thing that I was just thinking is that, is there a kind of like you mentioned about the phenotype of allergic rhinitis being different, but do you find, what are the challenges you find in managing patients with allergic rhinitis now during this COVID times? Like for us, we still can do in-person consults, and of course sometimes when there is a lockdown, the patients don't want to come if they don't have symptoms, so they do a tele consult and we fax them their prescriptions. But in general, we don't do so much of telemedicine, whereas there's a lot happening in India. So I was just wondering, what's the challenges you face when you have patients with allergic rhinitis in this COVID time?
In these COVID times, I've seen that patients tend to ignore the symptoms because they tend to brush it aside, saying it is a minor problem, or they feel that if they sneeze, they're going to be, subjected to a RT-PCR test for COVID. So they're so scared to come out. They feel that, okay, sneezing or something, people around them will say, maybe you're COVID positive. So there's a lot of mind block. There is what we call as KAP, that is knowledge, awareness, and practices of the people here. And there's a lot of taking vaccine hesitancy also. They feel that their allergic rhinitis might worsen with this. So there's a lot of challenges that way. We are doing telemedicine quite a bit. We have patients who we are able to access them. But unfortunately, this is difficult in the rural areas of India because the connectivity is not so good. And the borders also between the states get closed during a pandemic situation. And we get a lot of patients from different states. So they are also the ones who are suffering. And then they come with a really bad disease. And not only that, they also have a lot of social stigma associated with it and psychological disturbances. People are depressed, frustrated. Some patients even had suicidal tendencies because their allergies were not controlled. And now we have stopped the skin prick testing in the allergy clinic because we don't want to have close contact for 45 minutes with the patient. That is another challenge. So we don't know what they're allergic to. We are not able to educate them on that. And even for immunotherapy, patients are unable to come so often.
Thank you very much. That was very interesting to know the situation, because the situation varies from country to country, and the challenges we face are quite different. So, I mean, before you wind up this session as moderator, I just wanted to say a word of thanks to you for moderating this session, for actually navigating the whole panel discussion so beautifully. It's more like a well-woven carpet that you managed to actually bring us all together and brought out the good points. I'm not sure if we have questions that are still unanswered. And of course, anyone has access to me or to Raja or to Dr. Mahashiur or Dr. Guleria or to Dr. Soumya, and can free to ask questions anytime to us. We're there to provide whatever information and support in every way. I just request everybody, as a medical doctor, please make sure, try to convince at whatever level you can the public that vaccination is the only way out, but not without the continuing preparedness and precautionary measures. But vaccine hesitancy is a big problem, and there are big lobbies actually going against vaccination, which will only make the things more difficult for us to get out. And while I'm deeply stressed by what's happening in India, we are following very fast in Japan with just starting the state of emergency today in Tokyo and Osaka, because there's a spike in cases here also. So we all need, despite being very compliant, the Japanese population is very compliant. So we're all facing this, and we just pray, keep a positive attitude, try to educate as much as possible. And I think the virus has done only one good thing. It has brought the whole world together. It's cut across genders. It has cut across social status. It has cut across different nationalities. It is geographical borders, and taught us that life is more precious, and that love, care, and compassion should be the basis of our existence: love, care, and compassion. And with that message from APAACI, I would like to extend my greatest gratitude to all the speakers. Dr. Guleria, despite his hectic schedule, Dr. Mahashiur, Dr. Raja, also besides fighting in the front lines, Dr. Soumya, despite your hectic schedule, and to Sanofi for organizing this very nicely, and to all the audience who have taken their personal time to be at this webinar. And this is my message from APAACI. And after having said that, I'll give back this to Dr. Soumya.
Ma'am, thank you very much. It is a Sunday well spent, very informative, and such great panelists like yourself, Dr. Guleria, Dr. Mahashiur, and Dr. Raja. A very interesting and very relevant topic for today. I thank you very much for your time, ma'am. And
thank you, ma'am.
For arranging this excellent initiative. You know, all your academic initiatives are always very good. And this is one more feather in your cap. Thank you.
Thank you, ma'am. Means a lot. I think today we had the honor to have a panel of dignitaries who don't just define and propel the management of allergy and asthma, but are also working closely with government bodies to guide them during these pressing times, to devise strategies to collaboratively manage this pandemic. We want to thank Professor Ruby for giving us the opportunity to host the India chapter of the esteemed APAACI Allergy Week, along with the Indian Academy of Allergy. Ma'am, you've been an inspiration, and it has been an honor to host this very important event. We also had the opportunity to host Dr. Guleria, who we all know has been in the forefront leading the fight against pandemic and sharing some very interesting concepts and statistics in his talk. Of course, we want to thank Dr. Dhar and Dr. Mahashiur, who have been our guiding force to drive the novel concepts and the latest updates in the field of allergies and asthma. And despite their extremely busy schedule, they could be a part of this very important event. But ma'am, Dr. Soumya, it's not easy to organize and kind of collaborate and bring an event like this together. So thank you once again on behalf of the team and the entire Indian Academy of Allergy. So on behalf of Sanofi Allergy team, I want to take opportunity to thank all the doctors who connected today and spared their valuable time this Sunday morning. As a responsible leader in allergy management, Sanofi Allergy team will continue to bring the latest and the important updates in allergy management going forward as well. We wish you all and all your dear ones a very happy and a healthy Sunday and way forward. Thank you, everyone.
Thank you.